I am using face summer penetrant.
I am Marian Tricia A. Taduran.
I am Nikita Jardine Ramirez, and representing to you the case of atrial fibrillation and mitral stenosis. This is a case of 26-year-old woman from Nigeria, presents with sudden onset of palpitation and severe shortness of breath and coughing, with history of episodes of palpitation lasting for days or two, not accompanied with dyspnea and history of rheumatic fever at age of 14 years old. Currently 26 weeks pregnant with her first child and takes prenatal vitamins. Denies use of any medication, tobacco, alcohol, or illicit drugs. Physical examination reveals heart rate between 110 to 130 beats per minute, irregular. BP of 92/65 millimeters mercury, with a respiratory rate of 24 breaths per minute. O2 saturation of 94% on room air. She appears uncomfortable with labored respiration. She is coughing, producing scant amounts of frontisputum with a pinkish tint. She has ruddy cheeks and a normal JVT, with bilateral respiratory freckles in the lower lung fields. For her laboratories, on cardiac examination, heart rhythm is irregular with a loud S1 and loud pitch diastolic murmur at the apex. Apical impulses is non-displaced. Uterine fundus is palpable at the umbilicus and there is no peripheral edema. And the ECG shows in the V1 lead. For the diagnosis, atrial fibrillation caused by mitral stenosis. As you can see on the physical examination findings, the loud S1 and low-pitch diastolic murmur at the apex is also known as diastolic rumble. It is suggestive of mitral stenosis, which is likely caused by her atrial fibrillation as a result of left atrial enlargement and because of the increased blood volume associated with her pregnancy. Atrial fibrillation is caused her to develop pulmonary edema as evidenced by coughing, producing scant amount of frontisputum with a pinkish tint and bilateral respiratory crackles in the lower lung fields. Atrial fibrillation is the most common type of cardiac arrhythmia. In the healthy heart, the anus atrial node initiates all electrical impulses in the atria. In AFib, electrical impulses are initiated randomly from many other sites called ectopic sites, in and out the atria, commonly in pulmonary veins. These unsynchronized chaotic electrical signals cause atria to quiver or fibrillates rather than contracts. And an ECG AFib is characterized by absence of P wave and irregular narrow QRS complexes. Remind P waves represents electrical activity of the SA node obscured by the activities of the multiple ectopic sites.
This diagram shows on how a patient with rheumatic heart disease develops atrial fibrillation. So first, we will discuss the pathogenesis of RHD. Starts with the exposure to group A streptococcus. If there is a frequent exposure to this bacteria, it could lead to recurrent acute rheumatic fever. The recurrence of this can lead to rheumatic heart disease. Rheumatic heart disease will have thickening and fibrosis of the valve, and the most common is the mitral valve, thereby resulting to mitral stenosis. Due to the stenosis, it stretches and enlarges the left atrium of the heart. Then there will be irregularity in the contraction of the upper chambers of the heart, wherein it can be pulling. This mechanism will lead to the symptoms of atrial fibrillation. So we have different manifestation in atrial fibrillation. So first, palpitation. It is due to the adaptation mechanism of the body when there is increased left atrial pressure and volume. The diastolic rumble also happens when there is increased left atrial enlargement because of the increased volume, and it is associated with the pregnancy of the patient in this case. Due to progressive dyspnea, there will be compensatory mechanism that will lead to lymphatic drainage and the thickening of the basement membrane that will cause pulmonary hypertension. It will lead to hemoptysis. Hence, if there is no prompt treatment, it will lead to stroke and eventually heart failure.
There are 4 goals in atrial fibrillation management. First, hemodynamic stabilization. Second is rate control. Third is anticoagulation. Fourth is possible conversion to sinus rhythm. There is an algorithm for atrial fibrillation. We classify AF according to acute, chronic, or AF involved Parkinson-White syndrome. In acute, we further classify it to hemodynamic stability, stable or unstable. When we say unstable, the patient is in enjoyment of pulmonary edema, or the patient is hypotensive. We urgently do direct current cardioversion, followed by anticoagulation for 4 weeks. Anticoagulant due to increased risk of intraarterial thrombus formation that may lead to cerebral infarction or other distal ischemic event, and or antiarrhythmic agents to maintain sinus rhythm because the atria do not contract normally for quite some time. We can give propafenone, sotalol, or amiodarone. Then, the patient in hemodynamic stable, we proceed with giving ventricular rate control medications. To reduce AV nodal conduction, we give IV beta blockers, calcium channel blockers, or digoxin. Once the ventricular rate has been controlled, consideration can be given in reversing the underlying causes such as thyrotoxicosis, use of adrenergic stimulants, or worsening heart failure, so that the patient can undergo cardioversion to sinus rhythm. Once that cardioversion has been done, it is followed by anticoagulation, again for 4 weeks, and or antiarrhythmic agents to maintain the sinus rhythm. Then, in patient with AF involved Parkinson-White syndrome, we proceed with direct current cardioversion or giving procainamide. Procainamide slows propagation through the accessory pathway. There is no AV nodal blocking agents that is given in this patient, as it can paradoxically increase the ventricular rate. In patients in chronic AF, we proceed with giving ventricular rate control medications. Again, to reduce the AV nodal conduction, we can give digitalis or beta blockers. Chronically occurring AF requires long-term anticoagulation. Anticoagulation reduces the risk for stroke patient with chronic AF by 2/3. These patients cannot be cardioverted because the longer the patient is in fibrillation, the more likely it is to stay in AF as a consequence of electrical remodeling of the heart. New anticoagulants such as digabatran and rivaroxaban have been developed for use in atrial fibrillation, but oral vitamin K antagonist warfarin remains the most widely used medication for AF. Warfarin do not produce a predictable dose-related response. Therefore, the level of anticoagulation needs to be monitored by regular laboratory testing using International Normalized Ratio, or INR, in which the goal is INR 2 to 3. In incidence of bleeding due to excessive anticoagulation, in increased INR or in warfarin toxicity, this can be rapidly reversed with administration of vitamin K and fresh frozen plasma to replace clotting factors and provide intravascular volume replacement. If the INR increases to 6 to 9, markedly elevated, but no apparent bleeding, or is asymptomatic, hold the warfarin and the values will normalize over several days. So in the case, the patient is in her second trimester of pregnancy with history of rheumatic fever and presents with acute onset of palpitation and dyspnea, and found to have atrial fibrillation with a rapid ventricular response, she will benefit with cardiac rate control medications such as IV beta blockers or calcium channel blockers to slow down atrioventricular conduction and thereby correcting the cardiopulmonary symptoms.